My name is Ravi Rajaram. I'm a thoracic surgeon at MD Anderson Cancer Center in Houston, Texas. I serve as medical director of our thoracic center as well. In terms of the motivation for the study, Medicaid expansion really provided an opportunity, a natural experiment of sorts to understand how increasing coverage amongst a large swath of the population in a certain subset of states, how that would affect lung cancer care. And the reason I say that is this is a policy that, was implemented under the Affordable Care Act. And essentially, the policy to expand Medicaid was left up to the states. So some states could choose to expand the enrollment of patients within Medicaid by taking federal funds, and some states could decline that option. And the decision for the majority of states to either expand or not expand Medicaid was in January 2014. So having that kind of framework allowed us to look at lung cancer surgical outcomes, specifically wanting to look at whether or not this policy affected resection at a high volume center. And the reason that's a point of interest for us is when we look at this kind of the volume outcome relationship, hospitals that do a lot of surgical cases have improved outcomes. That's a bit of a tricky question. And for some specialties, for some types of operations like pancreatic surgery, esophagectomy, that outcome is that relationship is much stronger. Those hospitals that do a lot more of those operations, the data is very clear that they tend to have better outcomes. With lung cancer surgery, a number of studies have suggested that to be the case, although there's a little bit more debate. But still, overall, most studies, I would say, have suggested that hospitals that do more lung cancer surgery have better short and long-term outcomes. And so with this policy change, we wanted to kind of unpack this idea a little bit and understand, well, if you increase Medicaid coverage in a large proportion of the population, is that going to result in more surgeries at high volume centers? So that's kind of the setup for the question that we were interested in asking. When we look at our data, what we see is that both in those states that expanded Medicaid and those states that did not expand Medicaid, in either case, the likelihood of getting treatment within 30 or 90 days, and that treatment can be chemotherapy, radiation, surgery, whatever, the likelihood of receiving treatment actually within those time frames was actually diminished over the study period. So even in Medicaid expansion states, when we look kind of in more recent years, patients were less likely to receive treatment within 30 days or within 90 days compared to before Medicaid expansion. And that was, of course, true in the non-expansion states. However, when we look at the actual policy, we do these statistical analyses to see, well, what's the actual impact of the policy itself? It seemed like the slope of that line was less pronounced in hospitals residing in states that expanded Medicaid. So to the point that you asked in the question, the policy itself kind of reduced the overall trend that we were seeing in delays in care. And at the same time, it increased the likelihood of patients receiving surgery in a high volume hospital. And in this case, we defined high volume hospitals as those in the top quartile of lung cancer patient volume seen. So in terms of the clinical implications of that means that we're seeing a regionalization effect, which is something that you see in a lot of other countries where it's more restrictive as to what centers, what hospitals can do certain types of surgeries. In the US, we don't have that kind of organizational framework to mandate that certain surgeries are done at certain centers or certain hospitals. But the policy itself is leading to regionalization. That's what our data showed. And that is to say that more operations being done at high volume centers. And the corollary of that is that less operations probably being done at very low volume centers. I think we'll have to wait for long-term data to understand truly what the implications of that are. But some early kinds of signals that we're seeing is, well, on the downside, that may increase some wait times for surgery, right? If you have more patients at fewer hospitals, it could have the theoretical downstream negative impact of introducing increased wait times for surgery. I don't know that we're going to see that quite yet, but it's something to be on our radar and to be aware of. Additionally, if we look at, well, what are the outcomes at high volume hospitals compared to low volume hospitals within the data set that we looked at? And the outcomes were better at high volume hospitals. That is, patients were less likely to spend a long period of time within the hospital after surgery, so they got out quicker. They were more likely to have a complete resection of their tumor, what we call an R0 resection. So that's resection of the tumor without any gross or microscopic disease left behind. And likelihood of surviving the surgery, both at 30 days at postoperatively and 90 days postoperatively, well, the likelihood of surviving surgery was actually improved at the high volume hospital compared to a low volume hospital. So taking these little pieces together, maybe the downstream implications could be that, well, if we're seeing more regionalization of care, we may find that overall surgical outcomes are improved at these high volume centers. We're treating more and more patients within Medicaid expansion states. That's kind of multiple steps down the line in terms of making some jumps and some conclusions, but something that I think future studies will be interested in, to look at if that effect holds true. I don't think we truly know why we're seeing delays in getting to treatment, both within the Medicaid expansion states and the non-expansion states. Within the expansion states, I think there's some mitigation of that effect because by having insurance coverage from the get-go, those are patients who may be able to access oncologic appointments and imaging tests and all these other things a little bit quicker than if you're an uninsured individual. And so that could be one of the mitigating factors, just again, easier access to care, easier access to physicians, easier access to imaging, easier access to kind of treatment options. But why we're seeing the overall reduction in likelihood of receiving treatment within 30 or 90 days, both in the expansion and the non-expansion states, that's a more difficult question to unpack from a data set like ours. Some of the speculation I have is, well, maybe it's just some downstream capacity issues. When we have a new lung cancer diagnosis, we got to stage that cancer diagnosis with a PET scan and oftentimes brain imaging. Much of the time, these patients also require an invasive sampling of their lymph nodes. So with more and more of an emphasis on good clinical staging of their lung cancer, it may introduce some wait time to eventually getting that lung cancer treated or resected or radiated or what have you. But I think it is a difficult question to truly understand from our data set, but something we should really kind of be aware of because we know that the longer we wait to treat these cancers, in many cases, it could actually worsen survival. So I think it's something that we have to really be thoughtful about.